Good morning or afternoon or evening, whenever you're watching this. I apologize for doing this by video, but having done this lecture every day every 2 weeks for the past 8 years, I've gotten a little loco in doing this lecture over and over again. So the next 30 to 45 minutes, depending on how long this takes me, will be the introduction to your rotation with palliative care. Feel free to write down questions if you don't understand what I'm talking about. We'll touch about this a lot more during the time you work with me, but this should serve as a solid introduction. So first, let me tell you about what I do for a living. When I introduce myself to patients or their families, I actually don't say I'm a palliative care doctor. I used to say palliative care and people would go, "What's that?" So I actually introduce myself as a comfort care doctor. I tell people that my job is to help patients and families of patients who have serious illness with the challenges that life gives us. My job is to try and make things better for patients and their families, and I should stress the importance of families because more often than not, I'm working with the family as much, if not more, than the patient. My job, make things better, help with the challenges that life gives us, do what I can to help improve the quality of our lives for as long as God gives us life. My job is to help until we die, and we all will die someday. Even you will die someday, so will I. When I evaluate a patient, what I'm looking for is signs of weakness, signs of fault, signs where there might be areas to help support. And I like to think about things along the lines of like a tent. If you imagine a tent that has 4 posts to it, those are the structures. Of course, that's not showing up very well on the phone. I think you can see that on the phone. Turn this light off maybe. That'll help a little bit. See if that shows up a little bit better on the board. That's actually a little better maybe. You can kind of see me, I think. Can you see that? I hope you can see that. Anyway, the tent that you can maybe barely see reflects the 4 different basic disciplines that I look for, the different domains I look for in areas of weakness. And the first area that I would say I look for is the physical needs of the patient. The symptoms and signs that patients have with serious illness. Now, you should be used to doing that because you manage patients with illness. So pain and nausea and vomiting, things like that, you're used to managing. The difference is that many of my patients are approaching end of life. So the way you approach care for someone at end of life, their symptoms that they may experience might be a little bit different. When I was a resident in training, I was kind of taught basically restorative care. How to heal somebody and make them better until the day that they die. But we know that as people get closer and closer to death, we treat them differently. We are less aggressive with restorative care, and we do much more just for palliation. For example, you don't treat an 80-year-old with leukemia the same way you treat a 28-year-old with leukemia. Frankly, a 28-year-old with leukemia, you'll put them through the ringer. You'll give them treatment that might bring them close to death or at least make them very, very, very sick, understanding that the sacrifices that they're making are worth it because in the end you can save a life. Whereas when somebody's very old or with very advanced illness, you focus much more on just making them comfortable than you do on trying to restore care. Now that might also include the ICU or choosing to do an operation or starting dialysis or things like that. And the problem that I ran into and that you often run into is you aren't trained in how to manage those symptoms in what I call the gray area. That area where you're getting close to death, where you realize that trying to do anything really restorative isn't really going to work, but you're not taught how to manage those symptoms at end of life. And I'm going to give you 2 examples of how we're not well trained in managing patients at end of life. Now, every single resident, and I have a small audience with me today, Every single resident who works at this hospital has at some point walked into a room and seen a patient whose DNR, DNI, has bad respiratory disease, COPD or heart failure, is on a BiPAP and has mittens on. You've seen it, right?
Yes,
You've seen it.
Yes, all the time.
You've seen it, right? Why are the mittens on the patient?
so they don't take off the
So they don't take off the BiPAP.
BiPAP.
Why do they want to take off the BiPAP?
Comfortable?
Because it's uncomfortable.
Mm.
So why not let them take off the BiPAP?
Saturation.
They would die.
The saturation goes down.
Yeah.
So the oximeter goes down.
Mhm.
So in order to keep the oximeter at a level that we're comfortable with, we have to physically restrain a person from wearing a mask that's really uncomfortable.
Yeah.
And we can't intubate them. We would intubate them normally because they're DNR, DNI. So they're close to death. And as they approach death, very short of breath, you're physically restraining them from taking off a mask that they don't find comfortable. How does that sound?
Chaos? Human?
Pretty terrible, doesn't it? Why do we do it? Because we're trying to treat this oximeter. We're not looking at the patient in entirety. So what's the answer to this question? How do we keep this patient with an adequate oximetry level to make us comfortable?
Anxiolytic.
Well, it's a bit of a trick question because the first thing you have to do is get rid of the oximeter.
Yeah. Yeah.
Oximeters are very helpful, but in a situation like that, they're actually just an anxiety machine. Who do they make anxious?
Doctor?
Doctors, for sure.
Sometimes patients.
Well, let's not forget the nursing staff, right?
Yeah.
Because it's the nursing staff that calls you and says, Doctor, this patient's O2 sat is. So we are treating the nurse's anxiety. Sometimes the patients or their families, because they look at those numbers and they're focused on the number and oh my God, the number's too low. And if you go to the hospice unit, you will not see oximeters. They don't use them.
Yeah.
So how do they know what a patient's O2 sat is?
Doesn't matter at that point. No.
Well, they don't know. It doesn't really matter. You're treating the patient's symptoms. Now remember, this is a very specific situation. We have rules in place here. You can't intubate somebody. So they are somebody who's approaching end of life. Well, how do you keep somebody comfortable then? Because if you decrease that, you take off that mask, you put them on whatever they can tolerate, a venti mask, face mask. Sometimes they can't even tolerate that if they're really delirious. It might just be nasal cannula or high flow. But as their O2 sat goes down, they will feel a pretty awful feeling, which is that feeling of asphyxia. So how do you treat that?
To reduce the rates, like morphine or something.
Morphine. But wait a minute. If you give the patient morphine, isn't that euthanasia? Aren't you killing the patient? Because the morphine's going to reduce their respiratory rate, reduce their minute ventilation. Isn't that going to accelerate their death? Isn't that basically killing the patient? You got to speak louder because somebody in the future's got to hear you.
You're treating the symptoms.
You're treating the symptom.
Yeah.
And the reason that it's not euthanasia, future listener, is because the goal of giving them morphine is not to end their life. The goal of the morphine is to relieve the symptom of dyspnea, which you couldn't do any other way. You've tried antibiotics or diuretics or nebulizers or steroids. You've tried the non-invasive ventilator mask. They're not comfortable with it. So as a sense, last resort, morphine would be your drug of choice. How much morphine do you give?
As much the patient needs.
As much as they need to make them comfortable. How do you know they're comfortable?
Uncomfortable?
These.
So you can see that.
You all have two of them. Some might have one. You all have two of them. You look at the patient. How do they feel? You don't look at the numbers. You don't look at the oximeter. You certainly don't do a blood gas. There's no value there. You keep them comfortable.
Yeah.
The second way that we don't know how to treat people in this gray area is, I'm going to ask you a simple question. I don't want you to overthink it. An elderly person comes from home with advanced cancer, maybe some dementia. They come in, they have fever and chills and sepsis, and they're weak. And most importantly, they haven't been eating. Family says they're not eating anything. So what do we do in the hospital when patients don't eat?
NG10.
We stick a tube down their nose. And that solves the whole problem, doesn't it?
For the most part, yes.
For us.
What's a common symptom for us? He said for us, right? What's a common symptom at end of life? Anorexia, loss of appetite. It's incredibly common. My father-in-law died of heart failure. The most ominous symptom in retrospect was when he lost his appetite. He wouldn't want to eat anything. He could, he didn't choose to. Ask a patient with advanced cancer if they're hungry. They're not hungry.
Yeah.
My mother died of dementia. At the end of her life, you could take her favorite food, and my mother was an eater. My mother, pound for pound, small lady, big appetite. She could eat a lot of food. At the end of her life, her favorite food put to her lips, and she wouldn't eat it. Was she hungry? Clearly. What does hungry look like? We might know what pain looks like. We probably don't. What does hungry look like? Does a person in a coma look hungry?
No.
Does a person with end-stage dementia lying in bed look hungry? They might look cachectic. They might look frail and weak. But hungry is, excuse me, miss, where's my food? Knife and fork in hand, I'm hungry. Why do we put the tube down their nose? We treat ourselves. We also treat the families. And we fail to discuss with the families the fact that this is normal, that this is what happens. That as you get sicker and as you get older, loss of appetite is normal. It's part of this gray area, which I hope you guys can see. So it's important to understand how to manage the physical symptoms of a patient at end of life. The next area that I assess is the social needs of the patient. And by social, I don't refer to like alcohol, tobacco, and drugs. I talk about your life. What kind of people do you have around you? What kind of support do you have? And as you have figured out, or will figure out if you haven't already, that what you call a family or a home, especially in a community like ours in the Bronx, is up for tremendous interpretation. And we see a lot of people in this community who have very little, who have no friends, no family, who live on fifth floor walk-up apartments. I've seen countless people that I can't imagine how they can get by with no support, walking up 5 flights of stairs. I wouldn't do that. I'm able-bodied. And then when they get sick, their apartment becomes a prison. They can't get out of it, or if they're in the hospital, they can't get back to it. And with no friends or family, who makes decisions for them? And it's sad that so many of our patients are so socially isolated. Now, who can make decisions for you? Almost anybody, including friends. But we do see people who have no friends at all. And I like telling the story about a patient named Earl Green. Earl was a bad cirrhotic. Earl was a complete socially isolated person who would basically tell you when you walked in the room to F off. I need to draw blood, F you. I need to get a sonogram, F you. Now, I knew enough about Earl that he had bad cirrhosis and he had no family and no friends to support him. And I knew that Earl was going to end up in an ICU pretty soon. And without anybody to help make decisions for him, we were going to end up with a man stuck on a ventilator dying of cirrhosis, but legally bound to do pretty extraordinary things to try and save his life, even when it probably wasn't going to work. So I went into Earl to talk with Earl, and I said, Earl, I know you don't have any friends or family, and I will completely F off if you answer me one or two questions. And he laughed. And then I asked about what his wishes would be regarding artificial life support. And he told me, he said he would want temporary but not prolonged artificial life support. I asked him if he had a healthcare proxy or anybody who could designate as a friend or decision maker. He said no. He was completely alone in the world. Which is fine. That's, I guess, what he wanted in his life. It was sad, but that's what he wanted. We documented his wishes, and in a short period of time, within a couple of months, he was in the ICU on life support. And after an aggressive short period of time where we couldn't make him any better, where it was apparent that he was dying, we met with the ethics committee, and then we de-escalated care. If we didn't have Earl's wishes noted, and without a friend or family or proxy or surrogate, we would have tortured Earl Green. He would have stayed in the ICU for weeks with dialysis or multiple pressors, multiple transfusions, endoscopy for the bleeding, 5 antibiotics, all doing what we knew he didn't want. So finding that social support network is really important, especially in the Bronx. Who takes care of you? Where do you live? Who would take care of you if you get sick? And who would make decisions for you if you couldn't make your own decisions? The next thing that I like to talk about, to address, is the emotional needs of the patient or the family. And it's oftentimes the families that I work with more than the patients that come to the emotional needs of a caregiver or a family member. Elizabeth Kubler-Ross describes the 5 phases of dealing with bad news: denial, anger, bargaining, depression, acceptance. And it's really important to understand where a patient or their family member is on that spectrum when you approach them. Because if you approach a person who's really angry about the situation that they find themselves in because of their own illness or their loved one's illness more often, and you approach them with the wrong questions when they're angry, it'll go very bad. Trust me on that one. You come and talk about code status or withdrawal of life support, and a person who's so angry at the hospital because their mother over the course of the last 3 weeks has deteriorated, and they feel it's the negligence of the institution or the doctors or nurses that has gotten them there, valid or not, and you ask about withdrawal life support when they're angry, trust me from experience, that goes very, very, very poorly. You have to learn to read people. Where are they in their phase? If they're angry or they're in denial, be supportive. Express empathy. Help them out. Be a friend to them and do things to help them. If they're bargaining, help them understand what's going on. If they're depressed, support them. And if they've come to some kind of acceptance, well, that's the time more likely that you can really make some serious inroads in discussing options for care at end of life. I can't read my notes. Excuse me.
You want the light?
That's good. No, because they can't see the board. I don't know. Can you see the board? I don't know. We'll get back to some of this if we need to. The last of the 4 posts on the tent, which I think you can see, is spirituality, which you could also say called religion. Although, really, a religion is the way that you express your spirituality. Now, you might think, as a doctor, I'm supposed to talk about God? And the answer is absolutely. There are no atheists in an intensive care unit. People find their God. And in a community like ours, where religious belief is so high, the failure to understand that people's medical decision-making may come not from Cecil's Essentials of Medicine, if that even exists. Do they make Cecil's anymore? Is that book published anymore? Harrison's?
Harrison's, yeah.
Harrison still exists?
yeah.
Does Cecil's?
I don't know.
Marino's ICU textbook. Do you guys know what books are? They have
The
paper.
green one.
Yeah, the green one, right?
Yeah.
But what if the patient and their family uses the Bible as their medical reference? What if their faith is more with God than with the doctor? I've had numerous times where I've explained the scientific details in simple language to a family of how bad the situation is. Your father's kidneys have failed. His heart has failed. His liver has failed. His brain is almost dead, but not entirely. He's got a terrible infection, and I think he's on fire. At least there's a lot of smoke. I also see a tiger in the corner of the room. And the family says to me, I believe in miracles. I believe in God. I had no response to that before I understood how important spirituality was in the medical decisions that the families oftentimes make. And interestingly, we think as clinicians that they're in denial when they say, I believe in miracles. I get the hand, you know? You get the hand? I believe in miracles. Right? I had no response to that. Do you believe in miracles? Do you guys?
Yeah.
Well, I do because I've seen them. What you might call a miracle might be a little different. We might call CPR and resuscitation, just medically, technically, it's a technical thing. We delivered 200 joules to the heart restarted, we intubated them, a couple days later they woke up and they got off the machine.
Yeah.
No miracle there, it's all science.
That's explainable.
Very explainable science. Or is it a miracle? We've all seen patients that we didn't think were going to survive that did. Why? Well, it was the aztreonam and the vancomycin and the platelet transfusions. Or was it a miracle? It's really important to understand where people's faith comes from. And in the Bronx, so many people that I see have higher faith in God than in doctors. So to recognize that, to say things like, I'll pray for you, or to say, que Dios te bendiga, which if you don't know what that means in Spanish, it means God bless you. And if you say, que Dios te bendiga, to a Latino family, Marlon, what does it do?
Yes, they say amen. They will love you.
They will love you, and they do. I learned that expression about 7 years ago, working here. I heard somebody, a little old lady said that to me as I walked out of the room, and my Spanish is okay, but I didn't know what that meant, and I asked my resident, what does that mean? God bless you. Now, I had a hard time using that language at first. I'm not religious. I'm Jewish, but I'm not religious. So to say, God bless you, or I'll pray for you, that didn't feel sincere to me, because it wasn't part of my language. It was very hard for me. I felt like I was not being genuine by using words I don't use. But to say I'll pray for you doesn't necessarily mean I'm going to get on my knees and say a rosary. It means I'm going to think kind things. To say God bless you is a kind, we say it all the time if you sneeze.
Yeah.
God bless you. Right? I don't even know what that means. So it's really critically important to understand the role religion plays and how it will actually affect decisions patients make, not because of what you say, because of their faith. Now, sometimes people make terrible medical decisions because of their faith. You can explain how sick somebody is, and their family will say, well, we believe in miracles, so we're not going to stop a ventilator. I will repeat the story I told you, gentlemen, earlier for you. I had a 55-year-old man who had a anoxic brain injury after cardiac arrest. He was comatose. His brain was a mess. And we showed the CAT scans to his wife and explained the EEG and that he was never going to wake up. And she trached and pegged him because of her faith, Pentecostal Christian. A month after all of this, I happened to be on the ventilator floor. I walked into her room. I saw she was, I walked into her room. She's reading the Bible to her comatose husband. I popped my head in and I said, hi, I haven't seen you in a while. How are things? She looked up at me with a big smile and she said, everything's great. Now, the scientist in us would say everything is not great. You're reading the Bible to a comatose man. We would think she's in denial.
Mm-hmm.
But in reality, she's in acceptance. God will heal her husband. It just takes time. Or if he doesn't, that's God's will. But her decision making isn't made by what we tell her, because her faith is higher than us. We think we're gods as doctors. We're not. Now, it doesn't mean we totally abdicate our role as decision makers. There are plenty of people who, well, they trust us more than God. Occasionally they think we're in that level, especially culturally from some cultures. So if you're in a position where you feel like parentalism would be appropriate, do so. But be careful not to interject yourself too much, because they may not be asking for your opinion. They might not want your decision, because they might fall to a higher authority than you, meaning Dios. So spirituality is really, really important to assess and understand where they're coming from. And sometimes, to be honest, you have to use the language of God to help them make decisions. A patient who's suffering, why me? That's the book of Job, for those who don't know it. And I've even had patients that say, I can't choose, God will choose for me. Now that one I got stuck on for a long time until I realized God never chooses for us, not since Adam and Eve. And I've talked with patients and their families, and I said, Adam and Eve had a choice. There were consequences to the decisions. God didn't tell them what to do. So you have to make a decision based upon what you believe is appropriate, and God won't judge you for it. You're doing your very best. And that sometimes gets people off of that, I don't know what to do, let God decide for me. I don't know if I should pull the plug or do a tracheostomy. I'll let God decide. That's not how God works. God gives us choice. If that's where your belief comes from. Now, going back to our tent, which I hope you can see. If you've ever been camping and you have a decent tent, 4 poles doesn't give you a tent because the roof collapses in. So you need a center tent pole. And the center tent pole is education, which might be the most important thing that you have to do with patients and families. And if you learn one thing from working with me, and this will apply to whatever you do in internal medicine, it is to learn to ask the following question. Tell me what you understand about your illness. We presume way too much. And we talk at people with language they don't understand. And then when we're done talking at them, what do we say?
Do you have any questions?
Do you have any questions?
Open-ended.
And what do they say?
Nope.
Nope, because I don't understand a damn thing you just told me, and I'm too embarrassed to tell you that. I will never forget. I took care of a lady with bad cirrhosis. Once the lactulose kicked in, she was okay. She'd gone to liver clinic. She had a GI doctor, and I sat down with her and I said, tell me what you understand about your illness. And she said, I have cirrhosis. I said, that's right. What is cirrhosis? I don't know. Her husband's sitting right next to her, nice man, elderly man. Your wife has cirrhosis. Yes, that's right. Can you tell me what cirrhosis is? She was dead 4 days later.
Wow.
Why? Because that's what cirrhotics can do. But what was remarkable was this woman had seen multiple doctors and didn't understand what's going on. I'll give you another really good example. Not someone who's as uneducated as some we see in the Bronx. A couple of years ago, there was a lady who was admitted to the ICU. She had a history of pulmonary hypertension on home oxygen and got admitted to the ICU septic. And within about 2 days, they had every consultant but me involved, which means they should have called me. Everything was falling apart. They had ID and cardiology and pulmonary and renal and everybody involved, and they were doing everything they could to make her better, and they weren't doing a very good job because she was dying. So after about a week, I got involved with the case. And I asked the son,
The doctor for 510, pick up for
tell me what you understand about
pick up for 289
the condition.
family.
And he starts to repeat a lot of jargon, a lot of language that he'd been told by the ICU doctors, but he's clueless. Because they're talking to him like they talk to each other. And after he finished talking, I said, it sounds like you're kind of confused. He said, yeah, I don't really understand what's going on. And I said to him, well, it's really complicated. I'll keep it sick. I'm really worried that your mom is dying. I used the word. And his response to that was, it's that bad? I said, yeah, I think it is. I'm not God. I believe in miracles. And the ICU doctors are doing everything they can to save her life, but I don't think she's going to make it. And he thought about it. We talked a little bit more. And I eventually talked about code status, CPR, while she was on the vent. And he spoke with his sister, and eventually they made her they made her DNR. They didn't stop anything, just made her DNR. And the next day, she died. And after that, the day after, he called me to thank me. I just wanted to thank you. You prepared us for what happened. Now, you had multiple doctors, countless doctors involved in this care. But when I asked him what he understood, he was clueless. Why? Well, because people weren't being direct and honest with him. Part of it was the silo approach, something I didn't bring up in the last video I did. This is a new video. You don't know that because you didn't see the new video. Forget that. It's a digression. Sometimes when patients are really sick, we have multiple doctors coming in. Imagine a house, and you have one set of workers painting the walls, and someone else is putting in new carpet. Somebody's doing the wiring, somebody's doing the plumbing, somebody's fixing the ceilings and the drywall, and they're all working really, really, really hard. They're actually using the best they can find, because like the carpeting seems to keep getting messed up. Let's get the best carpeting, the most stain-resistant carpeting, and the best paint. And they're all working really hard in their own area. And I'm the one sometimes who walks up to the homeowner and goes, you know, your house is on fire, and there's no fire department coming. We get siloed sometimes. We don't look at the big picture as much as we look at all the individual pictures, which is frankly the best way to treat an ICU patient. You won't get confused if you keep it compartmentalized, right? We go organ system by organ system. But we lose track of that sometimes, and then we don't convey that information to the family. Now, there's a right way and a wrong way to talk about death. And actually, before we talk about death, pardon me, yeah, I'm back. We should talk about how we die and how you predict death, because that's not an easy thing to do. If you look at a curve that looks at how we die, the easiest patients to kind of predict are the cancer patients who are doing okay, and then they start to decline, and then they die. And there's actually a goodbye moment somewhere in here where the oncologist will say to the patient, I can't do anything more for you. It's been a privilege and an honor, and I'm so sorry I can't do anything more, but I'm exhausted with what I can do. And then there's a window in between that where they'll be referred to some kind of hospice program. And it's interesting that oncologists are really the only doctors that literally say goodbye to their patients. Now, also interestingly, oncologists are the only doctors, I guess besides infectious disease doctors, that can cure illness. Cancer scares people horribly, but many cancers, like most, are curable. You can't cure heart failure. You can't cure COPD. Without a new liver, you can't cure liver disease. But the way they die is different. and harder to predict. There's different ways that we die. Some, like my father, have an acute stroke and are gone. My dad was 89 and a half, anticoagulated, massive stroke, dead. Great for him, very quick and painless. Hard for family because you can't predict when this is going to happen. Now, some, the patients that we see, survive, and they're in the ICU. Now, some will get better. Some won't. And will remain with a very low quality of life, vegetative. For a family to try and make a medical decision in that situation is very hard because there's no chance to anticipate. Cancer patients, you should have a good chance. Most cancer patients that I see have had a chance to talk with their families about what they want as they get closer to the end, because the second they heard the word cancer, they thought, I'm going to die. And they've been treated for their illness for weeks or months or sometimes years, so there's more chance to anticipate. You cannot anticipate an acute neurological event, a stroke, traumatic brain injury. So hard to predict that stuff. My mother died of dementia, a very long, slow, drawn-out process. And for many, death is kind of almost welcome. For my mother, at least, we were relieved when she passed away because her quality of life was so poor for so long. Some families don't see it. Some families aren't ready for it. There are certainly some demented patients who take a steeper drop up at the end because maybe they have a secondary illness. But there's a lot of time to prepare for end of life with dementia. And hopefully to have conversations with families and loved ones about things like feeding tubes and artificial life support. My family was very well prepared. We knew no feeding tubes and no artificial life support. My mother never was in the hospital. She died at home with hospice care. But that's also not how we die. And actually, most of the patients we see die very differently. We see a lot of patients who have serious life-threatening illness and they bounce back. Not quite to where they were. And then they're doing okay for a while. And then they have another episode of serious, near life-threatening illness. And they bounce back. And they do it again. And again until they go. Can you name illnesses that fit this pattern? CHF? Cirrhosis? How about COPD patients? Right? And then the renovascular disease. Where they have these predictably unpredictable, near life-threatening illness, and then they bounce back. And how do we talk to them? Well, not as we should. Your heart's weak. Your kidneys are weak. And your liver's hard. And what's going to happen with each of those patients is they're a ticking time bomb. Do cardiologists see their patients die? Not often. Do they say goodbye to their patients?
No.
If you did a cardiac cath on your patient, you're a cardiologist, you cath somebody, and 2 days later they drop dead, was that an appropriate cath? If you put a defibrillator in somebody and the next day they drop dead, was it an appropriate defibrillator? Most likely was. Endoscopy or bronchoscopy, any of those things could be very reasonable. If you give somebody with non-small cell lung cancer chemotherapy and the next day they die, was that appropriate chemo?
No.
Probably not, unless they died of some other course, like a javelin injury or bus or Jaguar, right?
Yeah.
Because these doctors don't see their patients die, because there is no goodbye moment, and because we don't think about death as much as we should, these families are not well prepared when this happens, oftentimes. My father-in-law died of heart failure. I spoke to him on the phone hours before his death. He got home from a rehab. My mother-in-law calls me. I can't breathe, he says. said, Stan, you got to go back to the hospital. I don't want to go back to the hospital. You have to go back to the hospital. I was actually getting on a plane to go to California. So I get on the plane, I fly to California, I land, I turn on my phone, 8 messages from my wife, a couple from the ER, my father-in-law was dead. Well, almost dead. I talked to him a few hours before his death. My mother-in-law to this day does not accept that his death was natural course of illness. And at the end of Stanley's life, with no appetite, he could walk from here 20 paces to the door and got short of breath. He had end-stage heart failure. But when you sat down and talked with him, he was fine. The cirrhotic lady I described earlier, she was fine. Ticking time bomb. They just go boom. And you can't predict when one of these patients is going to have these illnesses. You know it's going to happen. You just don't know when. So if you don't have the conversations with them, the families won't be prepared. I thought of a very sad case recently. A 39-year-old woman who had postpartum cardiomyopathy with an EF in the teens and had lived for several years that way. Was not on a transplant list because she never followed up with her doctors.
Oh my
And what happens?
gosh. She dropped dead. Wow.
But not dead. Here.
Wow.
Vegetative. Survives her cardiac arrest. Is now comatose with anoxic brain injury. I meet her father. Tell me what you understand about your daughter's illness. She didn't tell me very much. I know her heart was weak. He was not in any way emotionally prepared to pull the plug on his 39-year-old daughter with anoxic brain injury, so she was trached and pegged. If maybe he'd understood her illness and understood this was an inevitable complication that could arise, maybe he would say, yeah, we talked about this. We were prepared for this. For the day when her heart would give out. When God would call for her. Instead, he was completely emotionally unprepared, and she got trached and pegged. So it's hard to predict when somebody's going to die. And it's hard to talk about death, too, by the way. It's really hard. One of the things that I've learned to do is when I have to ask hard questions, I say, I have a hard question to ask you. Is it okay? Then, no matter what I ask, they can't freak out because I told you it was a hard question. And it's important to just have that discussion with them. Talk about what they want, what their goals of care are, who is their decision maker, what they want for their life, and how they want to live their life until the day they die, which we all will do. That's a refresher for you, understanding you're going to die someday. 1 second. Got to check my notes, make sure I covered everything. Last thing. We talked about this a little bit already. My job is not to tell people what to do. I used to think it was, it's not. My job is to help people understand the choices that they have available for them, what their medical condition is, and then let them make their own decisions based upon who they are as a person, what their values are, what their preferences are, what their spirituality is, what their religion is. I remember talking with somebody about their mother or brother or father or sister, I can't remember who was on a ventilator. And I said, tell me about your loved one. And they said, oh, faithful to Jesus, read the Bible every day, went to church every day, Pentecostal Christian, believed in miracles. Now, this patient was stuck on a ventilator and never going to get off. And the family, was talking about a trach and a peg. And to me, it was like, well, that's exactly what the patient would want, because that's consistent with their spirituality and their values and who they are as a person. So it's not for me to tell them what to do. It's for me to help them understand what their choices are. I think that's all I got for you guys, whoever you might be. So I'm going to stop this video now. I hope I did a good job.